from the American Bifurcation Club. This is our monthly webinar, and we're pleased that there are about 200 participants from many different countries at different time zones joining us. So without much ado, we're going to start our case presentations. The first presentation will be from Kevin Croce from Brigham and Women's Hospital at Harvard, and he's going to present his case. The way we do it, the presentation is for approximately 10 minutes or so. And Gautam is on now. That's good. The presentation is for 10 minutes and followed by discussion. So the discussant will be Gautam Kumar. Then we'll have an international presentation from Dr. Omer Elamin from Saudi Arabia. And bless his soul, it's at 2 a.m. in the morning there, but he's decided to participate with us. And then Gautam was able to get his internet access, so he's on board as well. So without much ado, Kevin, let's get started with your case presentation, and you can share the screen now. As a reminder, this is not a CME program, but we would like to present and share our cases for best practices. Thank you, Kevin.
Thanks, Tanveer. I appreciate your stewardship in getting this organized and founding it. It's been something that's been very fun to be part of. Can you see my slides okay, Tanveer?
Yeah, just speak a little louder into the speaker. Thank you.
Great, perfect. I'll try to speak up, but if you need me to be louder, let me know. That's not usually something I have a problem with. So my case tonight is LED diagonal bifurcation. It's kind of a complicated medical story. 72-year-old female was sent to me electively for CABG reverse PCI consideration. Past medical history is known CAD, a CTO defined in 2017, managed medically, bilateral carotid endarterectomy, COPD mild, not severe, type 2 diabetes, and was actually admitted 3 months before I met her with a recurrent GI bleed and a type 2 MI that was complicated by some CHF. She had bleeding, which was cauterized in her jejunum, and a diagnostic cath was done at that point, not by me, where we defined her to have multi-vessel CAD, and she unfortunately had a peri-procedural right MCA stroke, which was managed with TPA with good recovery, and this is presumed to be from aortic plaque embolization during the cath. Revasc was deferred because of the stroke, and then she was having class 3 angina requiring regular nitroglycerin. So sort of came back to us after settling down from the stroke to have a consideration of what to do in terms of Revasc. Normal creatinine, the PET stress was quite remarkable with 40% ischemic myocardium, about 22% of it being some stress scored, and medium area of reversible ischemia in the LED and hibernating myocardium in the area where her CTO was on the right. EF was 50, and she had moderate AS, with a gradient of about 20 and not much mitral regurgitation. These are the diagnostic angiograms from 3 months prior. They were not able to get an adequate picture of the right coronary artery because I think there's severe osteal disease, and despite trying a couple catheters, it didn't sit well. You'll actually see better angios from the left side, from the left to right collaterals. Here's the cranial views. There were 3 of them. You can see there's a intermediate to indeterminate amount of LED diagonal disease, although this was subsequently abnormal on the PET scan, showing LED ischemia, and very nice collateralization of a large RCA territory from left to right collaterals, predominantly from LED septals, as you can see. Here's the caudal views. The left main had mild to moderate disease, some plaquing, but nothing that looked severe. And then you'll notice here that there's a obtuse marginal CTO with left-to-left collaterals that looks to be not that complicated. And so risk assessment from a syntax standpoint, she had a high syntax score of 37. Syntax 2 had sort of recommendation toward CABG for better long-term outcomes. But when you did her STS score for an AVR CABG, it ended up being a relatively high risk of mortality at 13% with complicated length of stay, et cetera. And so it was by no means with her comorbidity profile an easy case surgically. So thinking about complete Revasc, it's patient, lesions, and the operator. And we met as a heart team. We often have discussions about whether to pursue complete or limited revascularization. And this is a case where that's important. I mean, she had a long-standing CTO, which was managed medically successfully. So do you have to do everything if the patient's going to be sent for PCI instead of CABG? The other thing that matters, as you know, is the interventional procedure. I think modern PCI with physiology guidance and imaging guidance, we know in syntax 2, despite it being single arm, that we're able to convert patients with this type of disease to outcomes that look much better than syntax 1 and the PCI arm shown on the left, and also outcomes that at least are somewhat similar, again, not randomized, but controlled historically to CABG. And so I think how we do this is another important part of these conversations with regard to the heart team. So, her indication was class 3 angina. Given that she had a recent CVA, peripheral arterial disease, was frail, and actually had vein stripping which gave her poor conduits. With her moderate AS, it was recommended by our team that she be considered for multivessel PCI. And there's a lot you could fix: an LED diagonal bifurcation, presumably, a JCTO1 OM, and then an RCA, which has a JCTO4 score, which has been long-standing. So as you look at this, we kind of thought about what we would start with from a revas perspective. And I'd be interested in, Tanveer's opinion or Gautam's opinion. Would there be a particular way you tackle this, and would you be strong about what to do first?
Gautam, you want to go first? Gautam? Okay, go ahead.
Yes. So from what I can, are you all able to hear me okay?
Yeah.
We can hear you great, Gautam.
Okay, perfect. So from what I can see of the videos, I think the LAD diag bifurcation appears to be significant, at least angiographically. The videos are kind of playing choppy on my screen, and that's giving collaterals to a large RCA territory. I would probably start with the right first and try and see if I can make some headway there, and see if I'm able to get across the RCA. Cross the CTO there in the right coronary artery, and see if I can get across with some headway there, and move rapidly after that to the LAD, probably as a staged procedure, or if we move across real quickly, probably in the same setting as well. Been there, done that in both of those types. Now the LAD, maybe I'm not seeing it because it's playing choppy on my screen. Was any functional assessment done of the LAD?
Yeah,
itself?
It was abnormal on a PET scan, but I, like you, looked at this as sort of being intermediate severity, need more information. So I think where you're going is maybe a physiologic test, which we felt was also a good strategy in this case.
Absolutely. And if I was going to do a functional assessment of the LAD, I would do that after I revascularize the right, not before.
Great.
And explain that, Gautam, for the audience.
That's right here.
As we know, any functional test like FFR is both sensitive to the lesion and also sensitive to the mass of myocardium supplied. Oh, there we go. Oh, Kevin.
I didn't want to take,
Kevin, go for it.
Kevin, go ahead and explain that. Go ahead.
No, got it. You're on a roll. Go. Please explain. You're right on. Exactly. So I think, what Gautam's getting at is that,
please go ahead, Kevin.
Yeah,
Sorry,
when there's a lot of myocardium subtended, especially by the LED with an RCA, which is a CTO, you can have IFR and FFR values, which are going to be lower than if the RCA CTO is fixed. And this is one of many studies which has looked at the change in either IFR or FFR after fixing the RCA CTO. And you can see in aggregate, the IFR goes from 0.86 to 0.90. So in aggregate, it's not a large change, but you can see among these dot plots here, several patients move substantially. And so, thinking about how much this moves with regard to magnitude is something I'm cognizant of, because if the RFR IFR is 0.7, it's unlikely to normalize. If it's around 0.87, you've got a chance it's going to shift into the defer range after you fix the RCA CTO. And so that's something to be mindful of whenever you're doing physiology in one of these cases.
Absolutely.
That I thought I would point out.
Kevin, can I ask a few questions before I proceed? Why do they give TPA rather than embolectomy for the stroke?
Yeah, I don't know. I was not involved with your care at that time.
Okay.
That is one of the arms of our protocol at our hospital also. And it usually is done with sort of, stroke team conversation among the neurointerventionalist and our neurology stroke team. And so we've got a pathway to go in either direction. And it usually is, much like we do heart team assessment, the neurointerventional radiologist will look at it and we'll sort of talk about whether they go in and the timing and all that. And so in this particular case with an MCA EMBO, I think interventional strategy is certainly reasonable, but I wasn't there at the time that was chosen.
And the other thing about the goals of revascularization, is it complete in this case? Because, the surgeons ding us all the time and say, hey, you guys stent a lot of stuff and, look at 5-year outcomes, even in syntax, is that, the mortality rate of PCIs, there's a difference of 31% with CABG. So you're taking somebody with a surgical turndown, okay? I mean, what are your goals in this case? Are you going to be complete, or are you going to be just a couple of vessels?
Yeah, so I was going to play it by ear. I mean, I think that RCA is definitely treatable. Gautam probably couldn't see it, but it's a pretty tough CTO. It's a JCTO4, for which I think there's going to be a reasonable need to go retrograde because it's a long segment, it's calcified, and there's a lot of angulation. And so, we had looked at this in terms of the fact that we would pick off the easy stuff first, revascularize your left system in a stage fashion, going at the LED diagonal with a physiologic assessment, then probably the OM1, and then we would probably move on to the RCA after having a conversation with her about how she's doing and sort of whether she needs it from a symptom standpoint or a complete revasc standpoint. And the data for complete revasc outside of STEMI is, you know this well, it's moderately. You can't say that there's one study that's going to say it's the right thing to do. The meta-analyses point toward probably wanting to do that, but this is a case where I think there's some equipoise. And so because I was expecting we might need to go retrograde to get the right if we decided to do it, because the right was long-standing and she'd been asymptomatic from it, we wanted to fix the LED first because I thought that, that would pave any way for us to go retrograde through the second and third septal, which would be one of the avenues we try to do the CTO if it comes down to doing the RCA.
So go ahead and show your angiograms that after you've taken good time discussion. So go ahead, please.
Great. And so effectively, we went ahead and
I think it's a good view of the right. But you're right, Kevin. If the right is that complicated, I think you're absolutely right. It's probably safer to probably go for the low-hanging fruit first.
Yeah, and we didn't get a good picture of the right Gautam because it's osteal stenosed and the diagnostic angiogram is incomplete. We just never really got a good run of it. But you can see when you look in the AP cranial, I had in the other shots, it doesn't fill back very far. And so if you kind of summate the two without dual injections, it's definitely more than 20. It's definitely angulated and it's quite calcified. And so I think it's probably going to be a retrograde reverse cart case.
Yeah.
Awesome. So we went ahead and, looking at the angiography, as Gautam pointed out, I was really unclear. The PET said this was positive, but I wanted to confirm that. And then, usually if I'm going to do an LED diagonal bifurcation, I'll usually go with a 7 French system. And because of the plaquing in the ostium of the main, there was actually a little bit of guide dampening. So, this is just a trick we use to put a wire in the syrup so we can equalize and do all the RFR, IFR, FFR testing with the guide out, but stable. And so we equalize in the aorta, and then this is the pullback in the diagonal. And I kind of did a poor person's representation of where the major step up was, but it was really at the ostium of the diagonal as it's shown there. We then went ahead and did an RFR pullback of the LED and saw a little bit more of a measured pattern in terms of it, but the majority of the abnormality was just after the bifurcation and into this proximal segment before this first D1. And we felt that the second diagonal was quite sizable and it's something that we were going to want to protect. And so we went ahead and we're planning an LED diagonal bifurcation PCI using a DK crush strategy. We went ahead and wanted to do this with OCT guidance. I'll skip over Light Lab except to say that when we use OCT, it's been shown in recent stuff that we've participated in that it impacts what we do in terms of procedural planning and decision-making 90% of the time. And so I think imaging really matters for these. And so the ability to do this well is image guided in the current era. It changes what we do. And obviously in patients that are at risk for stent failure like her, we know that imaging reduces the incidence of stent failure. The way this is done is using a workflow that many have adopted now called MLDMAX. You find the morphology, determine if you need calcium modification, figure out to the best of your ability normal to normal areas to stent to, which is length, that's the L in MLD, and then use the distal reference diameter to determine what the diameter of the stent is. And so this is the pullback in the LED. You can see it happening, and I won't belabor this too much except to say that it was quite heavily diseased right distal to the bifurcation. And so effectively, we were able to define that our plan for stenting was right in this area, if you can see my cursor, about 15 or 20 millimeters after the bifurcation. And proximally, there's a nice normal landing segment just after D1. And so this ended up being our defined area of stenting normal to our ability. And then this is the OCT of the diagonal here. You can see that as the OCT pulls back. Again, osteally, there was quite severe disease. And so applying this methodology from the M, we had no more than moderate calcium, and the moderate segment was actually the proximal LED. This looked amenable by my mind to pre-dilation with an NC balloon. We defined the length of the LED as 25 and the diagonal is 18. And the diameter in the LED based on EEL sizing was 4.2 proximal, 3.6 distal, and 2.75 in the diagonal. And so with that in mind, we pretty much had our interventional strategy mapped out based on the pre-imaging. And so we needed a 2.5-23 in the diagonal and a 3.5-28 in the LED, and we were going to use the DK crush strategy. So at this point, it went straightforward. We dilated the diagonal, we dilated the LED, took a scout angio to make sure we had no major dissections. You can see there's some pleating in the diagonal, but this looked like it was stable and actually ended up being fine when we pulled the soft part of the wire back. We stented the diagonal as planned with a 2.5/23. We did a scout angio. This is important. If you have a distal edge dissection, the time in the DK crush, which is easiest to treat it, is right now. So there wasn't one, which was good. We stent crushed based on the OCT sizing with a 3.5 balloon. We rewired the diagonal, crossed with a 1.5 Takiro just to open the struts up, and sort of did standard dilation. 2.5 NC and D1, 3.5 NC and LED, a kissing balloon as part of the first kiss of the DK crush. And then we went ahead and went to stent the LED. As defined, you can see based on the OCT metrics, we're going right normal to normal where we wanted to, 3.5/28 science. Stent is deployed. I just did a quick scout angio to make sure I wasn't crossing that diagonal. I wasn't, so we landed it where we wanted to. And then, you know, at this point in the case, when you want to rewire, the two ways to do this are either to pot with a big balloon or to use a dual lumen microcatheter. In this particular example, I took a Sasuke just because I had, at this point, a 3.5 stent by OCT and a 4.2 main. You could have either taken a 4.0 and potted, but I decided to go down with a dual lumen microcatheter. As you guys know, it helps you to stay in the center of the stent to be able to recross so it's not substrut. Other than the cost of this, it's a nice way to deal with these, and it's especially helpful if you've pinched a branch and you don't want to pot around it. We took a Takiro again, and then went ahead and did standard kissing inflation, 2.75, 3.5. I don't know why these aren't showing, but we effectively potted 4.0. And so use standard sort of OCT guided metrics. And then on the back end, we had to make sure we did a good job. We wanted to make sure there's no medial dissections, look at apposition and look at expansion using this MLDMAX workflow. And so in the LED, there was a small intimal dissection proximally. You'll see this as it pulls back. It was not clinically actionable. The apposition was excellent. As you can see, the OCT makes it easy. The expansion LED is 90%. This is the first screen you see. It pops up. It shows you this, and you can see where the diagonal comes off at about 25 millimeters. There's an example of the bifurcation here. This is the OCT pullback of the diagonal. You can see in this segment, in the longitudinal view, it's well sized relative to the distal. And at about 35 millimeters is where the OCT comes back into the LED. And so with that in mind, we're going to do her OM1 CTO in about 2 weeks after I get back from holiday vacation. And then we'll talk about whether or not to do the RCA. And then thinking about a woman that's had a GI bleed, depth duration with bifurcation stenting, and CTO stenting is something that's important. But I think studies like STOP-DAP2, and when you use imaging, even in complex PCI, it seems to be safe to truncate dual antiplatelet therapy is something that we will advocate for her. And so, Tanveer team, thanks for organizing. I appreciate the opportunity to be here today, and happy to discuss, answer any questions. Thank you.
So going back on the DAP, thank you very much, Kevin. For left main DK crush, it should be a year, okay? There's no question about it.
Great.
Of course, if you have a bleeder, you should try not to do a DK crush, the left main, but the LED diagonal like this, are you going to be comfortable 1 month? I mean, tell me, what are you going to do? 1 month, 3 months? You're going to do a CTO intervention next? I mean,
yeah, I'm gonna leave her on it for 6 and probably not park it on her for a year. You know, the one thing for her is she's an ACS patient from 3 months ago. And so some part of it is protecting her stents and some part of it is protecting the lesions which have yet to rupture. And so, you know, if she doesn't bleed and she's not getting anemia and the GI docs adequately addressed her gastric ulcer, I'm going to try to extend it as long as possible. But at least, you know, if I have to stop it because she comes in anemic, I'll at least be happy that I can say with good conscience the stents are well expanded.
You know, you are a CTO operator, so tell the audience why you chose a Takura balloon and not, say, a Tuo balloon to initially dilate it up. Or
yeah, they're nice balloons for uncrossable lesions. They've got a stiffer shaft. They deliver well, despite the fact that it's a 1.5. Even though 1.0 balloons are available, our experience has been that they deliver quite nicely, and they especially deliver in bifurcation stenting where you're trying to pass through struts. And so when those don't deliver, what I'll typically do is take a microcatheter through like a Turnpike or a Corsair just to stretch the struts. But we've been doing less of that now since we've had Takiro. It's actually a nice way to do this. And you know, an unwrapped one is better than a one that's been used already. But even the reused ones tend to go relatively rapidly. And so we'll just do that to stretch the struts to then get the appropriate size kissing balloons in.
And did you now on the left main, do you do any imaging to make sure with the dampening there's nothing going on there?
Yeah, no, two things about that. You know, I didn't belabor this, but if you look at the profile of those RFR pullbacks, at least from a stability standpoint, the majority of the jump was in the LED, not in the left main. And so at least physiologically, the extrapolation is we're in good shape. And that's why I had the wire in the circ, because I wanted to make sure my guide was out and I could interrogate everything, including the left main, with the pullback adequately. I didn't go into it in too detail, but if you look at the terminal part of the OCT runs, there's one of them we had where the guide was backing up. We were able to see that there's stable disease there, does not look to be flow limiting. So an amalgamation of that plus the RFR pullback, which exonerated, I was happy leaving the left main alone as long as we were careful not to ding up the moderate disease there during the case.
So in our experience with trying to cross in between stent struts, great case, Kevin. I agree that Takero is an awesome option. There are some other options as well. I think the glider is a viable option in order to cross in between stent struts. The other good option is there is actually a 1.0 balloon like what Kevin alluded to that can sometimes just open up the struts or displace them enough. Alternatively, I agree with Kevin's strategy with trying to get a microcatheter down there. Sometimes just spotting that a little more tends to kind of move the struts out of the way and may help you get stuff in there as well. So there's a couple of different strategies that can be adopted in the difficult to cross side branch stent, jail stent, if you like.
All right, guys, I think that's great. Kevin, thank you for such a super case. So I'm delighted to introduce our next speaker who is up in Saudi Arabia at about 30 minutes past 2 a.m. to present his case. So Dr. Omer Elamin, an interventional cardiologist at a very renowned hospital, the King Faisal Specialist Hospital in Riyadh. And he did his training at St. Vincent in Worcester, Massachusetts. And he's a program director of the Adult Cardiology Fellowship Training Program. So Omar, go ahead and present your case and start sharing the screen. So once again, we'll have a 10-minute period of presentation, and then we'll have a discussion by Kevin and Gautam in this case.
Welcome, Omer. Thanks for being here so late. We appreciate it.
Thank you, guys. Thank you for having me. I appreciate it. Thanks, Dr. Rab and everybody else. All right, I'll go ahead and start the presentation. Are you able to see my screen?
Yep.
Yes.
Okay.
Yes.
So basically, this lady is a 69-year-old female with a history of diabetes, hypertension, and coronary artery disease diagnosed through stress testing. That was positive stress test. She was diagnosed with a uterine mass requiring resection through a total abdominal hysterectomy and bilateral salpingophorectomy. She underwent cardiac catheterization for pre-op risk stratification because the stress test showed moderately severe ischemia involving a medium-sized area of anterolateral myocardium. So we went ahead and did our angiography. The diagnostic cath showed a significant LAD D1 bifurcation, Medina type 111. You can see there the lesion is tightest at the ostium of the diagonal branch, which is really her only significant diagonal branch. Proximal to that, the proximal main vessel has involvement as well. And then distal to that, the distal main vessel again has another lesion that's a little bit distal to that exact bifurcation area, but it's like in segment. Also looking down at the diagonal, you'll see that there's another lesion a little bit downstream from the main lesion at the ostium. So ostial diagonal, proximal to mid-diagonal, and then the LAD itself, the main branch, both proximal and distal to the bifurcation. So this is the angiogram. And this just shows what we just spoke about. Again, the tight lesion involving the principal diagonal and another lesion just distal to it. This is a 6 French catheter, and it's the XB30. So just using that to gauge the sizes, basically guesstimate that this is about a 2 or so vessel in diameter, diagonal, and then the LAD is probably about 3 or so in diameter, just using the rough guide diameter. So that's another angulation, same lesion. And then we went ahead and started with the angioplasty of the diagonal. So initially I used a 1.5 millimeter diameter just to open up the ostium of that diagonal. And then I went ahead and used a 2.0 by 10 millimeter angioscope balloon to dilate the diagonal ostium and then to dilate the lesion further downstream in the diagonal itself, the proximal to mid lesion in the diagonal. I used the angioscope because I felt that the eccentricity of the plaque and the equal and even distribution obtained is probably better obtained through an angioscope balloon than with a regular semi-compliant balloon. So I used that just to help me out with the most likely fibrotic tissue. I did not do any imaging here. We do have imaging, but we just don't do it routinely. So I went ahead and just did that with the angioscope balloon at 8 to 12 atmospheres in both sites. And then I used a 2.5 by 12 millimeter NCU for a bit later on after I opened up both osteal and proximal lesions. And then I went ahead and did an angioplasty of the LAD itself at the bifurcation and a bit further distal to include both lesions right there and there. And I used a 3.0 by 20 millimeter Trek balloon inflated at 10 atmospheres. So coming up front with this lesion and the lady requiring surgery in the near future, that's potentially important surgery, I bore in mind that I'd like to avoid stenting if I can in this bifurcation. The rest of her vessels were unremarkable. She did have a small vessel disease, but that was not going to impact her overall prognosis. So this was the main lesion to fix. And basically trying to minimize the use of stents and trying to minimize the delay of her surgery. My plan was to try and use balloon angioplasty, see if I got a good result with that. And if I did, then I'd proceed with DCB, drug-coated balloon angioplasty. And if not, if I had any significant dissections or impaired flow, then I would defer back to a stent strategy, preferably one stent strategy. If not, then two stent as a backup. So with that, I went ahead and after I did each vessel separately or independently, I went ahead and did the kissing balloon angioplasty. And again, I did that here at this stage just to make sure that I don't have any significant dissections and I get an optimal vessel appearance as optimal as I wanted to have it before committing to either DCB strategy versus stent strategy. So if at this stage I had a significant dissection or impaired flow, then I might just change my mind and go to a stent strategy. And after doing the kissing balloon angioplasty, I used a 2.0 by 10 millimeter angiosculpt in the diagonal and the 3.0 by the same balloons that I had earlier. And I went up to 8 atmospheres in both vessels. And after that, this is the result I got. So as you can see here, it looks like a very nice result, relatively speaking. The main lesion in the ostium of the diagonal and the proximal main branch seems to be pretty much gone. The other lesion in the distal main branch is also pretty much gone, maybe very residual. And then the other lesion in the proximal to mid diagonal seems much better, but there is a little bit of a maybe a streak there, maybe a type A dissection there, but not so bad after all. She had TIMI 3 flow, the vessel diameter is better, maybe not quite less than 30% residual stenosis, but overall much better. So with that in mind and having TIMI 3 flow and no significant dissection, I decided to proceed with the initial strategy of drug-coated balloon angioplasty only. So I started off with the side branch and I used a 2.5 by 35 millimeter sequent please, which is the DCB of the B. Brown company. And I went ahead and inflated at 8 atmospheres, nominal 6 atmospheres, and I went ahead and kept it up for 1 minute. So that's the usual recommendation, is 30 seconds to 1 minute of inflation. With that, I got again, the result was maintained. The good thing is with the DCBs, you actually end up going longer than the usual angioplasty you do with a regular balloon, because this is a drug-coated balloon, and you have drug to protect the endocardium from restenosis secondary to balloon injury. So we usually go generous on these balloons in terms of length. And then I used a 3.0 by 25 millimeter sequent please balloon for the LAD. So I did the diagonal first and then the main branch, and I went up to 10 atmospheres in the LAD. And the final result was as follows. I got everything remained the same. I did not feel that there was any significant choanal shift or plaque shift at the bifurcation following the DCB balloon angioplasty, so I left it alone. I did not do another kiss. And that lesion distal, or in the mid diagonal, basically still had a residual maybe 40-50% stenosis, but it was small enough that it wasn't going to impact the overall prognosis of the patient. So this is the before image and this is the after image. Quite a remarkable appearance in terms of the initial bifurcation, and better appearance right here, and of course improved appearance here as well. So I was happy with that result and decided to come out and let her go, give her 1 month of DAP therapy, and then proceed with her hysterectomy. This is the final angiogram obtained at that time. So again, you can appreciate that it looks much better here. A little bit of residual stenosis here, and maybe a minor dissection, type A. But good TIMI3 flow. And that's another angulation, the AP cranial view, and looks good as well. So we left her at that, and we had her proceed with her hysterectomy, which occurred 2 months later, and it went very well, was uneventful. Now, 7 months post PCI, she was seen in the cardiology clinic, and basically at that time she had the new onset dystonia on exertion, but no chest pain. So it was kind of, is it not anginal equivalent? And because of the previously noted type A dissection in the diagonal branch and balloon angioplasty only, there was a lower threshold to bring it back to the cath lab and take another look, which we did. And based on that, this is the result we found at the 7-month angiogram. It actually looked a little bit better. So this lesion has healed, and the vessel has plumped up, and now has definitely less than 30% residual stenosis angiographically. The proximal bifurcation itself looks very nice. It maintained its patency. There was no restenosis, and the LAD itself, especially the lesion in the distal main branch, maintained its patency as well. So we're very happy with that result. Again, that's another angulation. And just to show you basically a comparison of the initial immediate post-PCI angiogram and the final angiogram 7 months later, you can see that there's a little bit, maybe the vessels do look a little bit more plump, especially of course here at the second diagonal lesion. But overall, very nice result here. Maybe a residual 20%, 30% stenosis here at the diagonal ostium, and the LAD itself looks very nice. So we're very happy with that, and that's what we had obtained. So I could stop here and take questions and leave it at that.
Omer, this is an excellent result in a very complicated patient that was beautifully managed, and it's illustrating a very nice non-drug-eluting stent strategy for managing these complex patients that for the group of us in the United States, the contemporary interventionalists, this is something that we don't generally do, which is one of the main reasons why I had you come and present this. And thank you very much for accepting this invitation in the middle of the night. I think the key string that we're going to see that runs through Kevin's case, your case, and upcoming my case as well, is the real world issues with long-term DAPT in some of these multiple overlapping stent issues, and how we deal with this in different ways.
Correct. Thank you very much for having me, first of all. And yes, this is an advantage that we have overseas that's not present yet in the US, these DEBs or DCBs. I've been using them for the last few years, and really the main advantage, like you mentioned, is reducing the need for DAP therapy, especially in those patients with high bleeding risk. And also in these complex cases, bifurcation cases especially, or small vessels where you don't want to commit to stenting. The incidence of restenosis is higher in these cases. So this is a nice option that you can have that can give you a long-term patency with results that are fairly similar when compared to drug-eluting stents in both de novo vessels and restenosis. So overall, I think I've been using a bit more of them lately in the last couple of years, and where I use them most is bifurcations and also small vessels. And if I do want to avoid, long-term DAP therapy in bleeders or so. And usually the general rule is that if you have less than 30% residual stenosis, if you have TIMI3 flow, and if you have a dissection grade A or B, then you have a good result that's acceptable, and you can proceed with drug-coated balloon angioplasty. So initially the plan would be to optimize, let me just show you this slide. Basically the ideal plan is to optimize lesion preparation. Use all you need. If you need to do a rotablation, lithotripsy, whatever it is, use whatever it is that you need to get a good, decent result by balloon angioplasty. And once you're done with that, you have a result that you like, then you can go ahead and use a DCB for deployment of the drug. Remember, the DCB is really meant to deploy the drug or deliver the drug to the lesion. It's not really meant to do the angioplasty itself. And if you have a suboptimal result, then you'll need to stent. So that's the general plan. The three main criteria, as I mentioned, are non-flow limiting dissections, residual stenosis less than 30%, and TIMI-3 flow or FFR greater than 0.8 will allow you to proceed with deploying a DCB rather than a stent. So
I like that you're bringing physiology into it. You almost wonder if there's going to be a defined PCI or defined GPS version of how we use DCBs and big vessels that you can assess physiologically. So that's cool. Is there data for that, or is that just sort of, you know, you don't want to leave it stenotic still, and if you need scaffolding to deal with recoil, you should think about a stent? Or is there some kernel of clinical info that actually drives better outcomes if you're using a DCB only? We know it does with stents, that's why I ask.
Right. No, so I think with these numbers, it's mostly consensus, but, you know, I think FFR is intuitive, or TIMI-3 flow used in other models. Yeah. And, you know, less than 30%, I think, is, again, just the old numbers from the days of POBA, where a result was considered, you know, satisfactory. There's data regarding, actually, interestingly, positive remodeling, which has been noted in these vessels. This is a slide that kind of demonstrates different studies that looked into the MLDs of patients with balloon angioplasty using a DCB versus stents, whether it be BMS or DES, in different studies. And the clear thing that's been noted in all these trials is that the MLD tends to get better. There seems to be a positive remodeling in patients who undergo balloon angioplasty with a DCB. So that's another positive result you find in these patients. There's data in terms of restenosis rates and target vessel failure in terms of comparing both DCB to DS and to regular POBA with regular balloons. And their overall efficacy is similar to DES and superior to regular balloons. This is a little bit of a slideshow on bifurcation lesions, how to approach them in patients with DCB. So if you have a side branch only, usually just deal with that branch, and you can wire the main branch for protection. And again, main branch only, just DCB that, and you can wire the side branch for protection. If you have both, like we had in ours, then you pre-dilate both side branch and main branch. If you have a good result, then you do the DCB in the side branch followed by the main branch. And then they mentioned kissing at the end if you have a suboptimal result at the carina.
I was going to ask you, do you ever
there's a question from the panel? You know, for DCBs, when would you consider intracoronary imaging to ensure that there's no medial dissection, etc.? I guess I'll give you this question since you probably have more experience with this than both Kevin and myself.
No doubt.
Yeah, so imaging is always a plus. I don't think there's a you know, right or wrong answer, but imaging is always a plus. And basically speaking, if I have doubt that the dissection is there, not there, significant, insignificant, then yes, definitely the imaging would be required, because that's going to determine whether or not I'm going to use a stent versus continue using the DCB. But if it's fairly clear, angiographically looks really good, I don't routinely use imaging. That's just my practice, but I can't say that that's you know, the ideal way to do it.
That's a lovely presentation, Omer. We appreciate your experience with something which I have none, so that's great. One quick question: do you ever do kissing inflation with the drug-coated balloons, or do you always do them sequentially?
So that's a great question. Let me show you why you should not do it. But again, the drug-coated balloon is meant to deploy the drug or deliver the drug onto the endothelium, and this image clearly shows why we shouldn't do the drug kissing balloon angioplasty, because of the areas that will be missed by that. So usually you just use it for deploying the drug. That's all.
Helpful. And then it's okay, as you said, to go back and reoppose the carina with a different kiss if you need to. There's no negative.
Correct. All the balloon does is just deploy the drug or deliver the drug to the endothelium, and all the work should have been done before that by balloon angioplasty. Lesion
what is the rate of abrupt closure with this balloon angioplasty dissection and drug-coated balloon?
Yeah, so basically it's going to be similar to the rate of it's just a balloon angioplasty to the regular balloon angioplasty. So if you have a dissection grade A or B, then it's less than 3% usually. That's the expected rate for these dissections. But I don't think there's any specific data specifically with these balloons versus other normal balloons. So I would extrapolate that information from the use of POBA in other cases, and that's usually the standard. If you're dissecting.
Thank you very much for really enlightening us about this approach. So Gautam Kumar is the next speaker.
Pleasure.
I think on share screen, Omer. And Mia, are you going to bring up his share screen, please? So Gautam is on faculty with us at Emory at the VA Medical Center, and is a high volume operator with complex PCI. And he's going to share a case with us today. And Kevin will be discussing it, and Omer can certainly participate with us as well in the discussion.
Great. I think Mia has my share slides up for me. Mia, you can go ahead and advance to the next slide. I have no disclosures. Next slide, please. Next. No, this is not the version of the slide that you got today. Look at the email that you got today, Mia. Yeah, you can take this off. This is not the one that you got today.
So if you unshare the screen, maybe I have the slides as well, Gautam, just a second.
And I'm sorry that I'm not able to share my screen because I'm on a telephone connection since my home Wi-Fi abruptly quit on me. I'm actually surprised it's this good.
We can see you great, Gautam. Is that related to the northeaster storm that's coming up the coast, or?
I don't know. We've not had Wi-Fi at work for the last week, funnily enough. And then so I said, okay, let me come home and we'll have Wi-Fi. And I came home and there's no Wi-Fi at home either. So,
Gautam, the slideshow that I got also shows up what you're seeing currently on Mia's screen. So.
Okay, let me try and share mine, although it may get cut off, but I will try. Are you able to see my screen? I'm going to cut my video.
Yes.
To maximize the bandwidth.
Okay, all right, okay.
Okay, so this is a 53-year-old male who presents with intermittent chest discomfort for 1 day, past medical history of diabetes with the A1C of 11.2, hypertension, hyperlipidemia. His exam was pretty much normal, and this was his EKG. As you can see, there are pretty clear ST elevations in 1 and AVL. And therefore, like any self-respecting interventional cardiologist, we decided to rush this patient to the cath lab. And these are the videos of the left system in araeocranial, LAO-cranial, araeocaudal, and LAO-caudal respectively. Let me know how this plays on your screens. Are you all able to see this, Kevin?
Yeah, not too bad. It looks like in the RAO view, there is some mid-LAD disease. Left main looks okay. And a little tough to see the circ in the caudal, but there may be something in the proc circ. It's a little hard to say, but there's, you know, kind of lumpy, bumpy stuff everywhere, but it looks like the LAD is probably the worst lesion that we can determine based on the angio quality.
Okay. And this is the AP cranial that we got. And I think you guys are able to see this with that diagonal.
Yes.
It looks like it's a second diagonal since the first diagonal was pretty small and wimpy. But we thought that that was probably the culprit lesion giving the lateral ST elevations in 1 and AVL with no real changes anteriorly or apically on the ECG. We wired that with resolution of chest pain, dotted and pre-dilated it. That subsequently resulted in restoration of flow in the LAD and in the diagonal. pardon me, the LAD flow was probably TIMI 3 to begin with. We weren't terribly amused with that. So that gave us several different options at this point. We could wire an IVUS to LAD to check it out. We could stent the LAD, we could stent the diag, we could stent both the LAD and the diag, or we could come up with other options. Thoughts, Kevin?
Yeah, in the view playing, concern there is important disease in the LAD distal to the diagonal. And I think, you know, imaging and or physiology, something's going to help you determine that. I like imaging here because it looks like you're going to have to stent really close to the LAD. So determining where the plaque is it, you know, IVUS or OCT assessed 111, and sort of what the sizing is and what the strategy is, and can you get away with a simple approach, or are you going to have to do some sort of full boat DK thing? I think imaging here would be very helpful.
So given the relative hemodynamic stability of the patient, we decided to proceed with intracoronary imaging of the LAD. We wired the LAD and performed intravascular ultrasound. We were unable to cross the second diag. And this is the poor man's co-registration, if you like. And I'm glad I did the poor man's co-registration because it probably comes across on this cellular connection a lot better than a video of the IVUS. As you can see in the first IVUS image, that's proximal. The guide wire is there. And you know, there's diffuse disease in that proximal LAD segment. This is the carina. You can see the wire going into the side branch here. And this is distally almost 360 degrees of calcium distal to the lesion. Again, you know, these are fairly concerning areas. That makes us think that this lesion may be a little longer than we'd like. However, we're not able to really get the IVUS into that diagonal even after that predel. So based on this, now, you know, we have a number of different options. We can think about doing atherectomy of the LAD and stent the LAD with a provisional strategy on the diag, atherectomy of the LAD with a 2-stent strategy, balloon and stenting with a provisional strategy, balloon and with a 2-stent strategy, and others. These are all just random thoughts that are going through my mind. Any other thoughts going through your mind when you're seeing this situation, Kevin?
Yeah, I think that IVUS profile of both important disease with a small MLA and a pretty big artery with a lot of calcium, I'd be either, you know, darn sure whatever vessel prep I do is going to be adequate. And based on the look of it, it looks like it may need atherectomy, unfortunately. And so, you know, your quick call case is turning into something to do right. You may need to invest some time in both the prep and also in, you know, rescuing the diagonal. I mean, I don't know. The diagonal size looks like it's, you know, I know it was active electrocardiographically, but I'm looking at it, Gautam, like, do we need to really perseverate on that? If you get his LED secured and that thing stays open and has good flow, do you need to kind of make it complicated? And I don't know the answer to that. I might just start sort of treating, getting things to dilate, give some nitro, and a little bit look at how it evolves. But it would be nice to keep it simple if possible.
Absolutely. And
Gautam, let me interrupt.
Go ahead. Go ahead.
The question was asked, why didn't you wire the LED when you're probing the diagonal? That's a question being asked.
The LED is wired already. You don't see it in this image. In the previous image, there was a choice PT extra support down the LED already.
Before you wired the diagonal, right? Or...
it was after we wired the diagonal, because remember, we thought the diagonal was a culprit lesion.
Okay.
Given the absence of ST elevations anteriorly.
And you had good flow in
okay,
the LED.
Let me...
So it makes sense. Yep.
Yep. So there are a number of thoughts that went through our mind here. A lot of the history here was unclear because of presentation due to the STEMI. I really suspected non-compliance due to the high hemoglobin A1C. And that made me a little leery in his case of performing a dual DES strategy for the LAD diag bifurcation, especially due to long-term DAPT concerns. And call it intuition that I'm relying on here, but we'll see what happened. We pre-dilated the LAD beautifully with that chocolate balloon 3/15, and you can see that balloon is inflated completely. We then elected to place a Triton side branch, Triton bifurcation stent. And as you can see, we're trying to position that. It has 4 markers. The middle 2 markers are the ones that has to come across the main branch. And you can see in the first image at the bottom left, it's too proximal. In the bottom right, it is too distal. And as you can see from where that wire is, that's a pretty long diagonal, and you'll see more of it soon. We got the Triton just right in the first image on top. I guess it's probably playing okay.
Yeah, we can see it.
Deployed the Triton there, and now you can see the full length of that diagonal in its glory. Subsequently, we up with the 20x15 Sprinter, and then placed the 38 Zions in there in the LAD. Completed that with a pot, and then opened up the stent struts, did a kiss, and finished off with a pot again to ensure that we get a nice round proximal segment. This was our final angiographic result, and you get to see the diagonal in its full glory. A little bit wimpy, but fairly long. It tends to go pretty far, even though it's not such a long, not such a high diameter diagonal. And we have a decent result at that ostium. I know Kevin's going to ask me, what did the imaging look like? This is what we have on IVUS. Again, the poor man's co-registration with the first image on top showing the proximal segment. Good expansion of the stent there, getting almost 3.5, which is what we hit it with. LAD and diag, and you can see Richard has made allusions to this in the past. If you see two nice circles of stents at the carina, that typically reflects a good result, and you're kind of seeing that here. And this is the distal calcified area that has been completely expanded at the bottom as well. Now, I think based on this result, we were pretty happy. Unfortunately, here comes the bad news. The patient was non-compliant with DAPT following discharge. 3 weeks later, he presented to an outside hospital with an anterior STEMI and was diagnosed with stent thrombosis of the LAD D2 that we created. He was discharged with the implantable cardioverter defibrillator. He continued to be non-compliant with CHF management and was unfortunately deceased about 1.5 years after this index event. So our intentions didn't quite pan out as we expected in this case, unfortunately.
I mean, bad stuff happens, Gautam. I think at the end of the day, you can, lick your wounds and take this one on the chin. At least I imaged it. I did my best to expand it. I took a chocolate that I know was 1-to-1 size because I had the IVUS images. And so, I mean, it's good practice. I mean, at some point, you can only do what you can do. We need patients to be partners with us also. Your point about taking the 1-to-1 size balloon to test it is important. I think the imaging there is great because if someone asked me, what size 1-to-1 balloon should I use to try and test this maybe resistant lesion? I mean, I think all the data shows that our ability to choose that 1-to-1, we're often wrong and we often undersize. And so, I've gotten burned by thinking my balloon's 1-to-1. I put my stent in and I find I'm still underexpanded, at which point it's really hard to fix. And so the cadence of how you did this is nice, and you tried to keep it simple for good reasons, as I think your instinct then later showed. And so bad stuff happens, but at least you feel a little better about it for the patients when you've done everything you can to prevent bad stuff from happening. I think management in this way, being parsimonious with not doing 2 DES. The one thing I don't know, and maybe I haven't used Triton to the extent that maybe you have, is it less noxious from a stent thrombosis standpoint than 2 DES would be the question. I mean, the flow profile may be a little bit better because of the design of it. And so that was one thing I wanted to ask you because you probably have more experience than I do with it.
So again, my experience is purely anecdotal because, having 3, 4, 5 cases where things have gone well doesn't equate to a large series of numbers. But in general, I've found that if I'm taking a non-DES strategy or a single DES strategy in a HPR patient or anticipating DAP disruption in a short duration, I have found that it tends to be a little less noxious. But again, you need more numbers to really prove it. I remember this particularly spectacular case of having a critical left main bifurcation lesion that I treated with Triton and a Cobra stent and in the left main. And the patient had a variceal hemorrhage on the table. and had blood on the ceiling of the cath lab. And we had to interrupt. Actually, we never started DAPT, and he did fine.
The one
Not
surrogate,
just interrupt, we never started DAPT.
yeah, because one of the things that always bothers me about culotte, especially in the left main, is getting the pant leg holes big is really tough. And so, if with experience with Triton, you're seeing better dualosity at the bifurcation piece, that may be a surrogate of why you use in a case like this could at least kind of give you an idea that it's easier to get good expansion. So yeah, that was great. Thanks for sharing. Not every case ends happily, unfortunately.
No, unfortunately not. Best intentions.
Yeah, but it does bring up issues with DAPT and, trying to do your best to do a good job, because you never know what's going to happen. People will come off it because they bleed, or they'll come off it because they won't take it, as in this case.
Yeah.
Gautam, this was an ACS-like situation, so obviously it was prothrombotic. But one approach I would have done is probably just as you did, ballooned open the diagonal and just put single stents across after you prep the LAD and potted and just left the diagonal without any metal there. I don't know if it changed if the course if you had not taken his DAP, because the first month is very critical in use of DAPT. But I don't know. I may have done it a little differently than using just a single stent, and rather than not have a lot of metal at the bifurcation. But
absolutely,
who knows?
Absolutely.
Omar,
I really don't think he took any DAPT after he left the hospital at all.
Gotcha.
Yeah.
Can't help it.
We all had that same instinct. You're kind of looking at that angiogram thing and kind of get away without dealing with the diagonal. But then at the same point, the diagonal is kind of what brought him in. And so you're a little bit stuck there.
Yeah, I know. That's what really got me stuck.
Yeah.
Omar, any opinion?
That's a great case. I don't have any experience with these dedicated bifurcation stents, but definitely a very nice demonstration of how to use it. I guess the length of the LAD stent would have been another thing. Could it have been shorter? It looks like he used a very long stent in the LAD. I don't know if that's going to impact the outcome in this specific case, but do you have to, or can you just use the Triton stent and maybe just balloon open the struts in the main branch? Do you have to stent it?
Yeah,
well, that's why I was showing the IVUS of the LAD, and the IVUS of the LAD looked awful, and that's kind of what moved us to actually address the LAD as well, unfortunately.
Okay. Yeah, and it looked worse after you ballooned the diagonal. It sort of, it always could be spasm, but it looked like it was kind of getting uglier as the case went on, and so you took a diseased LAD, sent stuff down there, and we're a place where I think it was, the IVUS helps you at least you've earned fixing it because you're doing it for a rational reason.
Omar, if you use a Triton stent, you have to put a stent in the main vessel. That's part of the technique.
Yep.
Gautam, is a question I get that needs to be answered for the panel. Did you see the question?
Best size of Triton stent. I'll let you take that one, Gautam.
Sure. So the Triton basically comes with a taper. For example, you have a 3.0 by 2.5 Triton or a 3.5 by 2.5 Triton. So the distal, the 3.0 means the proximal branch, the 2.5 means the side branch. And so it goes from the proximal segment into the side branch. You're now going to put a drug-eluting stent through the Triton to cover the actual proximal and distal vessel as well. So that's how I would size it. I generally tend to use a lot of imaging. Like Kevin, I also like a lot of imaging as well. So I tend to do a lot of imaging sizing for the vessel, both proximally and, if possible, the side branch as well.
And we'll learn, at least with OCT, which I'm probably most fond of and most facile with, as we do this light lab study, which is a 12 hospital, 40 physician study of OCT workflow. The last phase, which we've just moved into, is to apply it to complex PCI, particularly CTO and bifurcations when possible. And so the case I showed that I did last week, the first one was it was a light lab case. And so we're going to kind of start to understand the impact of workflow and contrast, either saving time or adding steps with, dual arterial, both limb image guided approaches. Cause it's something that only in the past couple of years that I started to apply in a very regimented fashion as we've learned how important imaging is. And so, how to do it well, which has been part of this project in terms of a workflow standpoint, is something we'll learn, I think, in the upcoming iteration of this study.
Well, gentlemen, we're coming to the end of time. Lovely, great, really good cases to review. And I hope the people viewing this got to learn a lot from this. I certainly learned a lot from this. And thank you, Omar. for being up to the night once again.
My pleasure.
And
Thanks, Omar. Really appreciate it was a
My
great
pleasure. Thank you, guys.
and thank you,
very
Kevin,
much.
Gautam,
for
presenting
having
great cases, and Mia and supporting our program through the C3 Academy. Once again, we'll have a date, I think January 27th, for the next webinar for the American Bifurcation Hour. Thank you, everybody, who joined
Merry
us.
Christmas and Happy New Year.
Merry Christmas, Happy
Thanks,
New Year.
everybody. Take care.
Thank you, everybody.